Hi, welcome to Case of the Day, and today is Tuesday. We have our 77th case, and that's titled Decoding Septum Predominant Hypertrophic Cardiomyopathy. So, this 56-year-old was found to have HCM on echo, came for a cardiac MR, and we'll just run through all the various things we have to do. This is the short axis that shows the septum to be hypertrophied, and if you can imagine it, from the base to the apex it's a spiral that goes in the counterclockwise, so it actually moves in 3 dimensions from the base to the apex, starting in the septum, going along the mid inferior wall and then the apical lateral wall. So that's the typical presentation of a septum predominant HCM. So the cine images show the increased end diastolic wall thicknesses, and the apical lateral wall is also thickened. Even though it doesn't reach 15 millimeters, that's fine. So the first thing is there is a septum predominant hypertrophy with increased end diastolic wall thicknesses. Then when we look at the cine 4 chambers and the LVoT views, you can see the late systolic apposition of the anterior mitral valve leaflet to the septum. There's this jet seen here because of the apposition, and we see a mild to moderate mitral regurgitation. The LA is also dilated, and if you look at the cine images, we can appreciate the SAM, the subaortic jet, the mitral regurgitant jet, etc. So that's the next line and the next finding that we have. The LA is dilated and there's no apical involvement, and that is something that we would mention. Then what we see, and we've started reporting, is the apical displacement of the papillary muscles. So these patients have an unusual attachment of the papillary muscles both towards the apex as well as towards the mitral attachment, and this is what leads to a lot of these problems, including the SAM, the LVoTo, and including changes in the apical region and in the mid cavity. So this is what we have to recognize. And if you look at the cine images, you can see the apical displacement of both the papillary muscles and the unusual and the abnormal attachment to the mitral valve. So we would add that as well. And then when we look at the cines again, you see this mid-cavity obstruction where in end systole the cavity is slit-like. And you can actually see a gradient here which starts in the apex and goes along the mid-cavity. So there is obviously a functionally significant obstruction in the mid-cavity, and a lot of these people may land up eventually having an apical aneurysm or apical infarction as part of this process. So we add these on too. The multiparametric doesn't add much. The T1 values are a little elevated as would be expected. T2 were normal, and the stir shows this unusual increased signal which is quite typical of HCM, not mentioned in the books, but it's something we see in patients who have significant hypertrophy. And then the late GAD images show patchy fibrosis, which involves about 20% of the myocardium. So we have to do the quantitative measurement as well. And then you add all of that together. That's the list of findings. Finally, when we look at the anatomy images, the MPA is dilated and it appears that the patient has group 2 PH. So this is everything that we need to mention in the report, and these are the various findings that we would go through, and in the end you would summarize this. So patients with hypertrophic cardiomyopathy need a comprehensive report covering all aspects of pathology from morphology to function to fibrosis, and a mention of any other ancillary finding that might be there. That's the classroom, my WhatsApp channel, and thank you so much for viewing this.